endocrine problems. Your objectives, some etiology and patho of something called SIADH, the syndrome of inappropriate antidiuretic hormone. Okay, this is the abnormal production or secretion of the ADH. So manifestations, what your patient's going to look like. Okay, they're going to be hyponatremic. Okay, hyponatremic. This patient, SI, they're soaked inside. They're going to have excess volume inside their body because their kidneys aren't being told to urinate. So they're going to be hyponatremic. They're going to have a low urinary output and they're going to increase body weight from all that extra fluid. They're going to have an increased specific gravity and the plasma osmolality and the serum sodium levels will decline. Here's some different causes. We're not going to focus on that too much. That's a physician-driven intervention to figure out where it's coming from. We're going to focus on what we're looking for and what the nurse does. So the three most important diagnostic tests of SIADH is the serum sodium level, which is 135 to 145. It has to be less than 134. Serum osmolality needs to be less than 275. And the specific gravity needs to be greater than 1.025. So those are the three aspects we're going to be watching for when we're doing treatment of SIADH. So what are we going to do? We're going to monitor INO, daily weights, level of consciousness. Remember, low sodium levels can make a patient very disorientated. A lot of times this patient tends to be fighting some sort of lung cancer. So you're going to see the physician order 3% normal saline, Lasix to get the kidneys up and moving, and then we're going to restrict PO fluids. Usually this patient somewhere between 600 and 800 milliliters in a 24-hour period. We're also going to be watching for the labs that we talked about, and we're going to be adding that sodium. So again, 3% normal saline, and very often a little bit of potassium is going to go in there too. So again, a fluid restriction, we're going to keep the head of the bed up a little bit because they're going to be soaked inside, so we don't want them having any issues with breathing. Possible seizure precautions and assistance when getting up from all that extra fluid. Then we go to the reverse, diabetes insipidus. And diabetes insipidus is going to be just the opposite. There's multiple reasons a patient can have diabetes insipidus. As you can see, it's all neuro-related. So we're going to be watching for decrease urine-specific gravity. We're going to be watching for increase urine output and decrease in urine osmolality. This patient, DI, they're dry inside. So in SIADH, they're soaked inside. In DI, they're dry inside. This patient will be thinking they are dying of thirst. They are not dying of thirst, but that's what their body's telling them. Very often, we're going to be giving the patient a medication called vasopressin or one of the pressins to help the kidneys slow down their production of urine. And so we know that the treatment's working when the urine specific gravity starts to go up, the urine output starts to taper off, so decrease urine output, and an increase in urine osmolality. There's also a test we can do called the water deprivation test. This is not something we're going to do until treatment has gone through quite a bit. And basically, we take away fluids from a patient and we see how they react. Again, this is not something we do at the beginning of treatment. That is something that's done. The physician's going to be present. Behavioral therapists could be present. There's a lot of different steps when it comes to completing a water deprivation test. So management. We are going to give IV fluids, just isotonic IV fluids. They are dry inside. They are dehydrated. Again, we're going to give an ADH replacement. The most common drug given is something called vasopressin. Sometimes a thyroid diuretic is given, but don't get hung up on that, okay? Many times the vasopressin or the DDAVP, which is another desmopressin acetate given, are given sub-Q. So remember, LPNs can manage sub-Q and IM injections. Utilize your LPNs efficiently, please. So what we're looking for, we're watching for fluid volume deficit. This patient's dry inside. So a decreased blood pressure, heart rate and respiration rate high. And because they're urinating a lot more, they are going to be sleep deprived from the constant urination until treatment starts to kick in. So we're going to monitor fluids, accurate daily weights. We're going to teach about the deprivation test long before we try it. And we're going to be watching those labs that we talked about. All right, on to your thyroid. So there's the hypothyroid and then the hyperthyroid here, okay? Your thyroid's located in your neck. You should not be able to palpate your thyroid. So here is the little patho behind the glands, the different hormones, the major functions of production and storage and release. A little bit of what the thyroid can do, metabolic rate. They monitor what you need for calorie requirements, your oxygen consumption. They do quite a bit. Remember, there's no patho on the exam though. So etiology of hypothyroidism. Essentially, hypothyroidism is your thyroid gland not working efficiently. So there's different types of thyroiditis, which we are not really going to get into, but you can get hypothyroidism from certain types of infections. But the treatment's going to be the same. So what does your patient look like? Okay, this patient has an intolerance to cold. They're slow moving. They have thick speech, slow speech. They gain weight rapidly because their metabolic rate has decreased. They can also get something that's a medical emergency called myxedema coma. And a lot of times what we see is individuals with myxedema coma, they're in the ER because family members, friends brought them in because they were so lethargic they couldn't wake them up. They had hypothyroidism but never knew it. And then something happened to trigger the myxedema coma. And then we were able to figure out through testing and labs that they have hypothyroidism. So predisposing risk factors to a patient with hypothyroidism going into a myxedema coma could be just an infection. They get a UTI. They get a small case of pneumonia, and all of a sudden we can't wake them up. Drugs. Opioids, barbiturates, so prescription drugs. A lot of times I've seen patients after surgery go into a myxedema coma because we're giving them pain medication after surgery, and thyroid is not something we do routine checks for before surgery. Exposure to cold, so all those fun people that like to do ice fishing on Lake Michigan, go right ahead, and some sort of any type of trauma. So diagnostic tests for hypothyroidism is something called TSH and free T4. These values correlate with the symptoms gathered from the H&P to confirm the diagnosis. We use a little bit of everything here. So the most common medication given to treat hypothyroidism is something called levothyroxine or Synthroid, however you'd like to say it. This is a forever medication. So once the patient starts Synthroid, they will be on it forever. So if the patient's like, oh, when I start to feel better, I can stop taking the drug. No, unfortunately, that is not how Synthroid works. It is a forever medication. You can read questions that we ask for H&P and nursing interventions for follow-up care. So diet for hypothyroidism, nothing fun, nothing fancy. Low calorie diet, decreased weight, and if it is caused from iodine deficiency, we do insist they put iodine in their diet. So now we jump to hyperthyroidism, okay? So an increased production and secretion of the thyroid hormone. Your patient with hyperthyroidism is going to have the bulging eyes, the facial flushing, muscle wasting, weight loss. Now, it sounds great like weight loss, but it's not fat weight loss, it's muscle weight loss. So not exactly what we're looking for. And a very common sign of advanced hyperthyroidism is those bulging eyes. So some diagnostic tests for hyperthyroidism, you have the TH levels, these will start to go down, and the T3 levels will be elevated. T3 and T4 I wouldn't worry about too much. Those may or may not be assessed. And then sometimes the physician's going to order something called a radioactive iodine uptake, which is a small pill-like shape that the patient ingests, and it is filled with radioactive iodine. Now, it's only filled with enough to work throughout the throat. Once it gets to the stomach, it will dissolve. So some oral medications that we see. So an antithyroid medication, the most common one we see is something called PTU. Forgive me, I cannot say that name, but so we're going to refer to it as PTU. This is the most common antithyroid medication that you're going to see on the market when the thyroid is hyperactive. Very often too, you're also going to see a beta blocker. Now, the beta blocker is not ideally for the thyroid itself, but when the thyroid starts to relieve too much TSH, what happens is the cardiac system gets involved and the heart will start to race. So the beta blockers are to strengthen and slow down the heart and regulate the circulatory system until the treatment for the hyperthyroidism is on board. Something we can also see is Graves' disease, which is brought on by an autoimmune disease, which we don't really know where it comes from. But about 75% of all the cases come from a hyperthyroidism active. This patient will also have the bulging eyes, which is the exophthalmos, as you can see here. They also may have something called a goiter. You can see on this slide that the goiter is when when the thyroid itself starts to enlarge. And this is something that you can see on examination. So in slide 37, you can see our young lady here. She's got a little bit of the bulging eyes going on, but you can absolutely see the goiter that's deriving from the thyroid itself. So very often, if the oral medications, the antithyroid medication, PTU, does not work, the physician is going to opt for a surgical procedure, either a total thyroidectomy or a subtotal thyroidectomy. Either way, the post-op the post-op care is going to be the same. So a couple things about teaching. We're obviously going to teach coughing, deep breathing, IS, supporting the head. This patient is going to be a little unique is because we're going through to the throat area and we're going to cut those muscles. You will see ENT surgeons a great deal of the time put a C-collar on the patient to support the head. We do not want a thyroidectomy post-op patient doing neck extensions. We do not want them looking up. We also are going to be watching ABCs. The first thing we're going to be looking for on post-op is going to be the patient's airway. How are they breathing? There is going to be some edema in the throat, so we're going to be very interested, and if there's any stridor, any difficulty breathing, we want to know immediately. We want to talk to that surgeon immediately. We're also going to be watching calcium levels. So we're checking for signs of tetany, we're checking Travoskos, we're checking Travaskis, all the signs of low calcium. Diet for hyperthyroidism. Diet for hyperthyroidism is going to be full 6 meals, high calorie, high carbs. We want them to avoid stimulants though, so caffeine, nicotine. Here is the compass of the nursing assessment. Nursing interventions might seem a little bit odd, promote good eye care, but with the bulging of eyes, it's very easy for the eyes to get dried out. There is a surgery now that can be done to kind of relax the eyes back into the eye socket, but that would be a later on thing that a physician could talk to the patient about. We're not going to worry about that right now. Big complication of hyperthyroidism is something called the thyroid storm. So it is potentially fatal, and it is when all the hyperthyroid systems are heightened. It often comes from a lot of stressors. And as soon as we see this happening, we are going to start treating the patient. I've had patients with temperatures almost to 105, and it can come on quite rapidly. They go into severe tachycardia. Remember, a standard hyperthyroidism patient is going to be on beta blockers for that sinus tach. So you could see a patient in a thyroid storm get up to 150s, 160s. So we're going to be watching for that. We're going to cool the patient down with cooling blankets and ice lavage. And we're going to find a room as quickly as possible that is a very decreased stimulation room. We want as least stimulation as possible. All right, on to Cushing's disease. So Cushing's disease is the most common triggered of high doses of corticosteroids. So basically the body is overproducing steroids. So a lot of times we see this moon face on the patient. This patient, because of all the extra steroids, will be blocking the calcium reabsorption into the bones. So it's very often that this patient will get osteoporosis and have multiple small fractures. So some ways we diagnose Cushing syndrome: the 24-hour urine free clearance. Remember in the urinary lecture, 24-hour urine clearance, we want to make sure that the patient gets up and urinates first thing in the morning, and after they flush the first urination, then they are collecting the urine. We can do scans to actually look at the glands, and low dose suppression test of drug therapy. The most common drug therapy is called ketoconazole, and ketoconazole suppresses the release of cortisols from the adrenal glands themselves. So it is a suppressor. This comes in PO and IV form. We tend to start at PO unless there is a greater cause or a critical situation. If the ketoconazole or medication of choice is not working, then the physician is going to very often go to something called surgery for Cushing syndromes, and very typically an adrenalectomy is completed. Adrenal glands are right on top of the kidney, so they are very easy to get to, but they can cause a lot of side effects, especially for the first couple days after the surgery, okay? We're going to be watching the patient's blood glucose levels because it can shoot up. We're going to be watching for any issues of cardiac, like hypertension, and we're going to be watching for potassium issues. The patient tends to go hypokalemic, so we're going to be replacing their potassium. This patient is also going to be on high doses of corticosteroids for the first couple days after the surgery. So we're going to be watching for signs, symptoms of skin breakdown, infection, hemorrhaging, poor wound healing, along with the hypertension, the high glucose, and the low potassium. This is going to be an ICU patient for the first couple days after surgery. Home care instructions. We do insist that the patient wear a medical risk blanket, bracelet, due to the fact that if they get exposed to high or low extreme temperatures, they can cause an autoimmune response, and the patient has been known to pass out. So if we have a Medallic bracelet on, we know exactly what we're dealing with and how to treat the patient as soon as they get to the hospital. And the opposite of Cushing's disease is something called Addison's disease. So Addison's disease is where the adrenal cortex is basically destroyed by itself, okay? Very often it will get more than 90% destroyed before the patient even has any signs of Addison's, but this is the patient that has the copper skin, they're kind of hunched over, they can get facial hair. The patient can also have an acute adrenal insufficiency called Addison's crisis. Now, this is a life-threatening crisis that we want to jump on as fast as we can possibly get on it. We're going to be doing shock management, so a lot of dextrose and isotonic fluids, along with a lot of hydrocortisone IV therapy. Patient with Addison's disease is going to be on different steroids for the rest of their life, okay? This is just an example of what they could be taking. And it is also very important, if you've never been on a steroid even for a short amount of time, it can really mess with your GI tract. So we want to know if the patient's having any GI discomfort. If they're nauseated, vomiting, cramping, diarrhea. We want to know. We do not want the patient to skip doses. But if we know that the patient is having a lot of GI issues, this route can be changed from oral to IM, and that way the whole thing can just be skirted along and we can completely bypass the GI tract altogether. So it's a very important teaching aspect. So diabetes type 1 and 2, we're not going to spend a ton of time on diabetes here. I want to talk about the complications. The majority of complications you'll find with diabetes, there's something called diabetic ketoacidosis, better known as DKA. So DKA is a very serious complication that occurs when the body produces high levels of blood acids called ketones, and the blood sugar is usually pretty high. Then we have something else called the hyperglycemic, hyperosmotic, non-ketotic syndrome, better known as HHNS. This is also seen in diabetic individuals. So what's the difference? Okay. So in one of them, you will see in type 1. In the other one, you will see in type 2. But here's the thing, the treatment's going to be absolutely the same. Once the patient's been established that they have a high blood glucose level, we can figure out the reason later, but the first thing that we're going to do is give the patient IV fluids. When we tend to give them high volumes of IV fluids, just isotonic solution, just to start hydrating the patient and diluting the sugar. Then insulin treatment, regular insulin, okay? Not NPH, not 70/30, nothing long acting. The insulin treatment is regular. It is short acting. We need it to start working immediately. And then we're going to start watching, we're going to draw blood for all the electrolyte levels because they're going to be all over the place. Then after we've stabilized the patient, then we're going to figure out why they went into DK and HHNS in the first place. So the big difference, if you are wondering, DKA is type 1 and HHNS is more type 2. Now you can get them reversed, but that's just what we see the most. Regardless, the first treatment is IV fluids, second step of treatment is regular insulin, and third step of treatment is electrolyte levels to get them balanced out.